we are on to the shoulder. So for Salem, our protocol for a standard outpatient is 3 views. We have an internal rotation Grashey, external rotation Grashey, and the axillary view. We have a good Grashey picture, good collimation, great positioning, which is the #1 thing. We can tell because we have this nice joint space here. Okay, we call that the glenoid joint space, glenoid cavity. Okay, so here's a few pictures to demonstrate, a couple sketches. This one really demonstrates the good joint space, good collimation that you need for a Grashey. Be mindful of your rotation of your patient. If you rotate too much, the ribs will be in the way. If you don't rotate enough, the joint space will not be open. So just be careful of that. You can see here, this one's not rotated enough. This one's much better, joint space. If I zoom in, you can see the difference. So our technique's going to range anywhere from 70 to 80 kVp, anywhere from like 4 to 8 mass, could go up to 10 depending on the patient size. This all depends too on if you're using a grid or not. A shoulder is one of those exams where it's kind of in the middle of the body when it comes to thickness. It's going to create a little bit of scatter, reduce your contrast. So a grid can help you out in that scenario on those bigger patients. Now, if you're using a grid on a bigger patient, you want to use a little bit higher kVp and mass, okay, because that grid is going to attenuate. Whether you use a virtual grid or a physical grid, it will attenuate those scattered photons or lower energy photons, okay? So more technique is going to be needed to get a good picture. You're going to underexpose if not. It's going to be a little bit more patient dose, but sometimes that's necessary to get good images. And on smaller patients without a grid, you can use a lower kVp, 70, even 65, on really small patients with a lower mass of like 3 to 5. You know, it's going to save them some patient dose. It's not going to overexpose and burn out your image. It's going to look nice and clean. So moving on to the axillary view, we can see our patient's going to be supine, laying on the table. Our beam is going to be traveling in from the side of the table here at about a 15 to 30 degree angle, kind of going right in to that shoulder joint, right at that axillary line, to try and get that joint space there. Okay, and there's a little bit of sketch to see what it looks like. I'll show you on the next slide here what it actually looks like when we take that x-ray. Okay, you see the beam coming from the side of the table, shooting in at the patient like this, and this should be the end result right here. Okay, this is good collimation. We got our humeral head, great joint space here. So in class, we went over how angling your patient can help with positioning. What I say by that is angling them this way so their feet are closer to you at the edge of where the table would be right here. Okay? Why do I say that? Why is that important? Because when you're here, normal, you see where the central ray starts out. The table is going to get in the way of the x-ray tube. And you risk crushing the patient's feet with that tube, especially when you're hyper-focused on your positioning here. Okay, so be very careful when you're maneuvering this tube. It could be very easy to crush a patient's feet, and that's the last thing you want to happen. So by angling them this way, it allows you to now bring your central ray and your tube outside of where that table is. Okay? It starts more over here, shooting in, and you don't have to worry about the tube hitting the table at all. So really practice that. Put the pillow at an angle before you even bring the patient in the room. It'll help you remember. And one last thing you got to think about. So next up is the trauma Y. So this is when a patient can't lift their arm up to about here. You can do an axillary to about here, I would say. Anything lower than that, we're going to end up doing a Y view. Okay, the Y view here, we see the humeral head. We don't necessarily see the glenoid joint space, but we see where that humeral head is sitting. We can see if there's going to be an anterior dislocation. We can see if there's a posterior dislocation. And this is a nice picture with the scapula nicely superimposed on itself. Now, I encourage you guys, if the patient can stand up, to do it PA. Stand them up. This is going to be the position of our patient. So when I zoom in here, this is how it's going to look for collimation purposes. So here we're going to look at a bad trauma where they can't stand up, and you have to lay them down supine. And why I say lay them down supine is because it's easier to line up your beam perpendicular completely with the image receptor. Now, when you roll them up onto this shoulder, you're going to get your Grashey, the hurt shoulder, and when you roll them away from it and you're going to x-ray the upside, that's going to be your Y view. Okay, you can see you're using a yellow sponge for both of these pictures, maintaining patient comfort the whole time, always talking to your patient. And if they can't tolerate it, we're just going to do an AP image. Okay, we're not going to roll them onto this shoulder. We can always do a shoulder Y though. Last case scenario here is aiming our beam at an angle. You can see here, image receptor not in line with our x-ray tube. What that's going to cause is distortion. Yes, at this angle with our tube, we're going to get the shoulder Y. Okay, at this angle, shooting in this way, we're going to get our Grashey, but it's going to be very distorted. It's not going to look like these two pictures. It's going to look a lot wider because of the distortion here. If somehow we could get our board at this angle, that will eliminate the distortion. With our board here being horizontal, we're not going to be able to do that. So, and in a Y scenario, you can see we're never going to be able to line that board up. We're going to have to go right through our patient, which is impossible. And if we were way down here, the OID would be ridiculous. We'd have to really build them up underneath here, but that's more something for a C-arm. If you had, your other end somewhere like this, you got your beam traveling through, yeah, you're going to get a shoulder Y. This is what you'll achieve, but it will be distorted, I promise you. Make sure that's your last resort. Now, techniques for a Y view are pretty similar, maybe a little bit more mass. Especially if you're doing a PA, it shouldn't be any different than a regular shoulder x-ray. 70 to 80 kVp, anywhere from 5 to 10 mass should be ideal. There's more of our AP. There's our Grashey. There's our shoulder Y. Alright, that pretty much does it. Bring any questions to me that you have, and good luck. Get a lot of practice in.